Okay, good morning, everybody. Welcome to our weekly medical grand rounds. Before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. We are actually hosting our annual Wensel Sherbaniuk Founders Lecture. And so without further ado, I'd like to welcome our GI Division Director and Section Chief to introduce the lectureship and our speaker.
Good morning. Thank you, Dr. Kazam. So welcome to the Wensel Sherbaniuk Founders Lecture. So I believe this is the 22nd year. And so before I introduce our distinguished guest, I just want to go back a little bit of history. So as I look back at Dr. Sherbaniuk first came back in 1960. At that time, the most interesting quote that I have from him is that people thought that he probably wouldn't be able to make a living as a gastroenterologist in 1960. There was no division back then. And there actually was not a gastroenterologist in Western Canada. So he was one of the first ones that had the vision to do that. And a few years later, he brought in Dr. Wensel, and they were the first two division directors. They started the division of gastroenterology. They were the founding members of the Canadian Association of Gastroenterology. Another interesting fact I didn't know is that Walter Mackenzie, who the center is named for, was one of the first presidents of CAG. So very interesting in terms of back then. So in terms of a distinguished lectureship, I'm very pleased to have our guest this year, Dr. Michael Camilleri, who is Professor of Medicine, Pharmacology, and Physiology at Mayo Clinic in Rochester. He has numerous research interests, but these include GI motility, neurosciences, gut neurohormonal control, obesity, IBS. He's out over 1,300 publications, numerous fellows. One of our fellows is joining him next year. He's the past president of the American Gastroenterological Association, currently still associate editor of Gut. So I'm very pleased to announce and welcome Dr. Camilleri to Edmonton. Welcome back.
Thank you so much. Thanks for the introduction. Thanks for having me back. We were working out that I was here about maybe 20 years ago, and it's great to be back to share some thoughts with you. For the fellows, what I'm going to present here is actually a leading article that was published in the journal Gut. And I had this idea and spoke to the editor, a friend, Imad Elomar, and I said, I've got some ideas. He said, put them down and let's see where we can go with it. So I came up with 9 and he came up with 1. So it was a fair share. So I'll explain to you the one area which he contributed greatly to in the article, and it's, you know, the information is there for if you want the details about references, etc. So I'm going to deal with 10 principal reasons why gastroenterologists and hepatologists should be treating obesity. And if you can remember this one principle, that treating obesity is relevant to health in general, as well as impacting the GI and liver disease itself. Okay, sorry. So you all know this. We all know this. The prevalence of obesity continues to increase. The cardiometabolic risk factors continue to increase, certainly in U.S. adults with diabetes. And this is tracking the prevalence of obesity and also the cardiometabolic risk factors, which continue to increase over the years. And so this is a very significant factor as we deal with patients' issues as they come to see us in the GI clinics. And these are the 10 principal reasons I'm going to try to summarize for you. Obesity is a significant risk factors for GI, pancreatic, and liver diseases. Treating obesity really should start when the patients come to us in the GI clinics and not sweep this under the rug. Treatment is directed at GI structure, incretins, and metabolic functions can be very helpful in the management of obesity. We as gastroenterologists and hepatologists understand the effects of incretins, including the importance of metabolic associated fatty liver disease, which used to be called NAFLD. And it's actually MASLD now, I understand from my fellows. It's metabolic associated steatotic liver disease. Endoscopic and bariatric interventions continue to be the gold standard for treatment of obesity. Obesity significantly impacts the treatment and complications of IBD, and obesity may impact more than one GI or liver disease in the same patient. So we have to keep our minds open with regard to other complications of obesity. And then we have opportunities to resolve obesity comorbidity in patients following liver transplantation. Remember, one of the most common indications for liver transplantation is actually metabolic associated steatotic liver disease, also called NAFLD. And then obesity is impacted by the gut microbiome. This is the area which Emad El-Omar contributed greatly to, and I will only skim on this because it's not my area of interest or expertise. And then there is actually some preliminary data regarding fecal microbial transplantation and glycemic control. So that's the overall 10 points that we're going to be covering, and I'll give you some more details regarding each one of these points. This is from the New England Journal of Medicine, and of course, we know that there are complications of obesity affecting the entire body. And if you look at the gastrointestinal complications, there are certainly ones that are identified in this general medicine article. And I'm going to go into greater detail, but we mustn't forget the importance of the cardiometabolic and cerebrovascular morbidity, as well as the cancer comorbidity associated with obesity. So if we look at obesity with regard to GI, pancreatic, and liver diseases, these are patients that are presenting to all of our GI clinics. They may present with liver disease, as we said, with NAFLD, with hepatocellular carcinoma, gallstone disease. You all remember, as I do when I was a medical student, fat, fertile female of 40 is more likely to get gallstones. So there it is. Colon disease, including diverticulosis, Clostridium difficile infection, de novo IBS following bariatric surgery. These are more prevalent in patients with obesity. Esophageal disease, obviously gastroesophageal reflux disease, and complications such as Barrett's esophagus, and eventually esophageal adenocarcinoma, gastric cancer, pancreatic diseases, including acute pancreatitis, and now more and more infiltration of the pancreas with fatty tissue, and then small intestinal diseases, including diarrhea and bile acid diarrhea, and anorectal diseases, especially dysenergic defecation, which has now been shown to be more prevalent among people with obesity. So let me give you an example. And of course, because of my interest and bias for bile acid diarrhea, I've chosen this as one example, which you may not be aware of. But in a study we did at Mayo Clinic on about 215 patients with diarrhea predominant irritable bowel syndrome, 44 of these had evidence, metabolic evidence of bile acid malabsorption or increased bile acid synthesis. And when you look at the patients who have the same clinical symptoms of diarrhea, urgency, abdominal pain, relief of pain with having a bowel movement, in other words, patients with symptoms suggestive of irritable bowel syndrome with diarrhea, those who have the metabolic disturbance are more likely to have a significantly greater, higher BMI. So obesity is a significant risk factor for bile acid diarrhea. Intervention in patients in the GI office provides opportunity to impact significant morbidity and mortality. Now, we all know this. There is a greater likelihood of death, unfortunately, with higher BMI from cardiovascular disease. An elevated glycosylated hemoglobin is one of the strongest predictors of stroke and acute myocardial infarction in patients with type 2 diabetes. In meta-analyses, prediabetes increased the risk of all-cause mortality, composite cardiovascular diseases, coronary disease, and stroke. And the all-cause mortality is actually related to the sorts of levels of blood sugar that we often just dismiss. We say, okay, this is just pre-diabetes. So when we're seeing our patients with gallstones in the clinic and they happen to have a blood sugar of 120 milligrams per deciliter, think of that as an opportunity to intervene. Now, you probably use millimoles per liter, so I put both sets of numbers there. Treatment directed at GI structure and function can treat obesity itself. This is a figure from an article I wrote almost, 10 years ago or something. And it was an invited article from Gastroenterology. And I wanted to make the point that incretins actually have a very significant impact on the function of the stomach in particular. When food enters into the GI tract, we have upper GI hormones like cholecystokinin and gastrin and ghrelin that are being released. And they have some effects on the way in which the stomach itself works. So cholecystokinin delays gastric emptying. And then we have food coming down into the distal small intestine and resulting in the release of GLP-1 and PYY, oxyntomodulin, hormones that come into the portal circulation and have very significant effects on vagal afferent function, again, to slow down stomach emptying. And we're going to fast forward into what is the revolution of incretins in the management of obesity. Quite honestly, it really arises from this applied gastrointestinal physiology. In fact, the potential actions of GLP-1, glucagon-like peptide 1, GIP, which in the olden days, 40 years ago, used to be called gastric inhibitory polypeptide, but it's now been renamed glucose-dependent insulinotropic peptide. So when it was first studied by people like Victor Mutt in Sweden and Steve Bloom at the Hammersmith Hospital where I trained, it used to be called gastric inhibitory polypeptide because guess what? It inhibited the emptying of the stomach in experimental animals. But then, of course, it was realized that it has a very significant effect on glycemic control. So glucose-dependent insulinotropic peptide. And then glucagon itself, which is not an incretin, but it's certainly a hormone which all three have very significant effects on the liver, on the gastrointestinal tract, on glycemic control through the pancreas, through effects on islet cells, and also on thermogenesis in the case of glucagon, and therefore energy expenditure. So you can see that these are very important metabolically, and they are very relevant to the management of obesity. Indeed, this is an example from this lovely paper in Lancet Gastroenterology and Hepatology, which documented the effects of these three main hormones and therefore the agonists that are being developed as treatments for things like non-alcoholic fatty liver disease. And they have effects on glucose production as well as glucose control. Glucagon is something we need to remember is important as an insulin secretagogue and at the concentrations that are found in the islet cells of the pancreas. And it can signal through the GLP-1 receptor on the beta cells so that the beta cells produce insulin and therefore you get better glycemic control. And indeed, the glucagon receptor itself is not as important as the GLP-1 receptor on the beta cells of the pancreas. Now, over the last 20, 25 years, there's been incredible advance in the modification of the GLP-1 structure so that from being a peptide hormone with a duration of action of literally minutes, 10 minutes or less, we now have different molecules that have a much longer duration of action. So I'll give you a couple of examples. Exenatide was the original modification, and this modification resulted in a half-life of about 3 to 5 hours. And so exenatide could be administered to patients with type 2 diabetes twice a day. And that's how it was also introduced as a treatment for obesity. Now, fast forward and link the molecule to covalently to albumin and to other large molecules, and you end up with molecules that have a duration of action of about a day, like liraglutide, and subsequently also semaglutide, a larger molecule, which is not cleared by the kidneys, and therefore it has a duration of action of 5 to 7 days. So over literally 20 years, we've gone from a peptide that has a duration of action of literally a few minutes and is very interesting for experiments, but not very relevant for clinical practice, to now having these incredibly potent GLP-1 receptor agonists. And then a very interesting further development, which is to make semaglutide orally dispensable by co-formulation with this molecule called SNAC or caprolate. And Dan Drucker from Canada, of course, from another part of the country, was critical in the development of this type of molecule. And as one can see here from the pharmacokinetics, whether you look at the effects on glycosylated hemoglobin or you look at GI adverse effects, the subcutaneous formulation of semaglutide and the oral formulation have very little function, very similar functions. Now, if you think, again, you look back about a decade ago, surgery was clearly the best treatment for obesity. And this was from a review that Andres Acosta, my former fellow and now colleague, and I wrote with Bahram Abudaye, who's a complex endoscopy, bariatric endoscopist. And we compared and contrasted Roux-en-Y gastric bypass with pharmacological intervention. And over the last decades in particular, the results which you're going to be seeing in the next few slides with the GLP-1 receptor agonists, especially the dual and even the three hormone receptor agonists, are now approximating the level of weight loss that one can see, for instance, with sleeve gastrectomy, and almost getting as close as the degree of weight loss seen with Roux-en-Y gastric bypass. So treatments directed at GI structure and function can treat obesity. We started off, and I remember this, with orlistat, which was an inhibitor of pancreatic enzymes that caused steatorrhea, caused a lot of gas and steatorrhea and diarrhea. But now we have much smarter tools, and those tools can sometimes be combined. We have endoscopic approaches. We have Roux-en-Y gastric bypass, which the surgeons can do. Sometimes the roux limb is normal, but the gastric remnant enlarges. And so endoscopists are able to go back and refashion the shape of that gastric pouch so that the patients can't eat so much after they go to eat, and therefore restrict the amount of calories before they can start to feel full. So the combination of endoscopy and surgery can also be helpful. But we're also seeing combinations of several of these hormones, which I will show you in some examples coming up. Certainly glucagon, GLP-1, GIP, and also amylin. There's a medication which has been around for some time, used for type 2 diabetes. It's called pramlintide, but there are now derivatives of much longer duration of action called cagrilintide, which is now being developed as an anti-obesity medication. And amylin, of course, also has an effect on the beta cells of the pancreas, and so it helps with weight loss, and it also helps with diabetes. So my point is that we no longer use in common clinical practice the agents which seem to be working more at a central level, and much more the current therapeutics are targeting the GI tract. And one of the reasons is illustrated by this network meta-analysis done by Kera and Hassan Murad and Sid Singh. And in this study, they showed that really of all of the medications, the incretin-modifying agents, as well as phentermine topiramate, were the two most efficacious classes of medications. The other medications, as you see here, are not as efficacious as those types of medicines. And of course, the newer incretin agonists have now really outstripped the benefits that one can see with phentermine topiramate. This is a network meta-analysis that we did a couple of years ago, even before tirzepatide, retatrutide, which I'll describe soon. And when we did this network meta-analysis, we found that subcutaneous semaglutide delivered weekly or liraglutide delivered daily were the most efficacious. And you can see here the degree to which you could have about 10 kilogram or 10% weight loss in these patients. And whether you look at adverse effects or efficacy, again, the greatest benefit was overall from semaglutide and liraglutide. What about other newer medications? Well, this is tirzepatide. It's a dual incretin agonist, works on GLP-1 and GIP, and it's approved in the United States for the treatment of type 2 diabetes. It improves glycosylated hemoglobin. It markedly reduces body weight. Now you're seeing we're regularly getting to the point of 12 or 15 kilograms of weight loss. This is typically in a 6-month period of time. And this is now on fast track for approval, at least in the United States, for the treatment of obesity. And I'm anticipating, if it hasn't already been launched and I missed the headline, it's likely to become also approved for the treatment of obesity. But it's already available for patients with type 2 diabetes. A triple agonist, this is not yet approved, retatrutide, This works on GLP-1, GIP, and glucagon. And again, one can see efficacy in type 2 diabetes. This is a phase 1b study, improvement in glycosylated hemoglobin, improvement in weight, and you see the dose response. Now, I thought it was really interesting. Between July and August of this year, there were 6 papers in the Lancet and New England Journal of Medicine. Both the journals seem to be competing to publish the latest American Diabetes Association abstracts. So I'm going to show you in the next 2 slides. This was published in the New England Journal of Medicine in June, documenting, as we expect, the efficacy of retatrutide for obesity in a phase 2 randomized controlled trial. And you can see it works both for men and for women, and it works both for BMIs lower than 35 and for people with BMI of greater than 35 kilograms per meter squared. So that's the New England Journal of Medicine. Well, 1 month later, or maybe the same day, okay, the Lancet did not want to be outdone. And so they published retatrutide in type 2 diabetes, et cetera, et cetera. So you can see the interest of the general medical journals in publishing these very efficacious treatments for patients. Gastroenterologists understand the effects of incretins. So this is a study we did thanks to funding from the National Institutes of Health. And we looked at things that my colleagues in endocrinology make easily available to us. For instance, DEXA scanning so that we can study body shape and distribution of fat. So liraglutide has effects on fat body mass without affecting lean body mass. It affects appetite and satiation. And of course, it has effects on glycosylated hemoglobin. And that really was well known in the literature. But our focus has been on the effects of these agents on gastrointestinal function and particularly on gastric function. So this is a somewhat complex figure slide. I'm going to take you through it. So here in the top left side, you can see that liraglutide at 5 weeks produces a marked delay in gastric emptying. This is that same 320 kilocalorie, 30% fat meal that I discussed yesterday evening. At 16 weeks, there still is a significant deceleration of gastric emptying, but you can see that overall, these 67 patients who received liraglutide did have tachyphylaxis in the effect of the medication while the patients were losing weight. Note the stability of the data for the 60-something patients who received placebo. Also, you will notice that gastric emptying at 16 weeks tended to be faster than gastric emptying at 5 weeks. But more importantly, we started to see and document that the degree to which gastric emptying was delayed, both at 5 and 16 weeks, but particularly at 5 weeks, was a significant factor in the degree of weight loss in these patients. And the other thing that we found was that patients who had the fastest gastric emptying were the ones who had the greatest degree of weight loss in response to liraglutide. So keep in mind that these are GLP-1 agonists that slow gastric emptying. And this is something that hadn't been fully appreciated. But does it have an impact on the degree of weight loss? Well, certainly these data that we produced would suggest that there is a correlation between the amount of weight loss and the degree to which gastric emptying is delayed. This was published literally a week ago. And we reanalyzed those data on 67 patients, which I summarized with that median and interquartile range graph. But now we've plotted the actual data for all the patients at 5 and 16 weeks. And what we find is that about a third of patients, which you can see here, have normal gastric emptying throughout that 16-week period. 174 minutes is the upper limit of normal for gastric emptying with that same 320 kilocalorie, 30% fat meal. On the other hand, we have some patients you see in blue who have delayed gastric emptying at 5 weeks, but they have normal gastric emptying at 16 weeks. And then we have a third group of patients who have delayed gastric emptying that never gets better. Now, this is going to be relevant when we come to the final point I'm going to make, which is very relevant to us in gastroenterology and to anesthesiologists, because the concern is that these patients with persistent delay in gastric emptying may be the ones who have the greater risk of aspiration and complications therefrom. Sorry. It isn't just our studies that show the presence of GI adverse effects, if you wish, as part of the mechanism of action. But these are data from a meta-analysis on oral semaglutide. And what they show is that if you see the data here, the contribution from GI adverse effects to weight loss is significant for most of the studies, even though it's not the predominant reason why people are losing weight. So certainly these agents have effects on appetite, they have effects on the hypothalamus, but they also have GI adverse effects. And so by just looking at the GI adverse effects, we also know that these agents have effects on the gastrointestinal tract. We actually did an analysis as well from the literature, and more than 24,000 randomized participants in the different studies, and you can see that the propensity to develop nausea is also significantly associated with the degree of weight loss, again confirming the importance of GI to the development, to the success. We all know that ultimately GLP-1 agonists are going to delay gallbladder emptying, and therefore patients are going to have a propensity to developing gallstones. So let's keep in mind the possibility that our patients with upper abdominal pain on these agents may be having gallstone or other biliary diseases. Hepatologists and the American Association for Study Liver Disease has already made some announcements and recommendations regarding the treatment of MASLD and NAFLD with the GLP-1 receptor agonist. They've made recommendations, and the more fibrosis you have, the more you need to consider using a GLP-1 receptor agonist in addition to the first-line approaches, which of course will be diet and other standard of care treatments. Obesity is associated with liver disease, and there is evidence in the literature of response of that fatty liver disease and transaminase elevation to treatment with incretin agonists. And so I'd like to point you to this particular systematic review of the literature, which shows that visceral fat is reduced with GLP-1 receptor agonists, and overall there's also an improvement in intrahepatic fat. This was with tirzepatide, remember, a 3-hormone receptor modulator, and as you can see, there's an improvement in AST and ALT, shown at the top here, and this is dose-related. It's better with tirzepatide than it is with a relatively low dose of dulaglutide, which is, again, one of the other earlier GLP-1 receptor agonists, and also there's improvement in factors associated with apoptosis and biomarker of fibrosis in the liver. Endoscopic and bariatric interventions are still the gold standard for treatment of obesity. Yes, I do still believe that if the patient really has significant obesity, this is still to be considered as one of the treatments, even though, of course, the pharmacological agents are really catching up. So we as gastroenterologists are involved with our bariatric endoscopists and surgeons to manage the obesity. I think that sleeve gastrectomy in particular is the most commonly performed procedure, but Roux-en-Y gastric bypass is also performed. And then there are opportunities in bariatric endoscopy. And my colleagues at Mayo certainly have a lot of experience with sleeve gastroplasty. So this is just a summary of what I could glean from systematic reviews in the literature. Endoscopic sleeve gastroplasty has about a 16% total body weight loss at 18 months. Not perhaps as good after time, and not as good as sleeve gastrectomy. But again, duodenojejunal bypass liner, this is another device that is available that we can use in endoscopy, and that could significantly impact glycemic control. And I think it's also important to keep in mind that there's also some initial data on the combination of bariatric procedures with the use of the pharmacological agents, the GLP-1 receptor agonists. And yes, we do know that weight can plateau after a sleeve gastrectomy. And this is the opportunity to think, are there pharmacological approaches that we can apply to help that patient continue on the trajectory towards improved cardiometabolic safety? Talking about cardiometabolic, there's no doubt that bariatric surgery, shown in the darker color, is better than standard treatment control group in all of these cardiovascular adverse effects: heart failure, composite cardiovascular events, coronary artery interventions, etc. So there's no doubt that if you get the patient on the trajectory of weight loss with bariatric procedures, you can improve that patient's general health. Let's talk about inflammatory bowel disease. Let's come back to the GI tract. Now, this was a very interesting study, I thought, that looked at the effects of tumor necrosis factor alpha inhibitors in diverse inflammatory diseases. And these included rheumatoid arthritis, psoriatic arthropathy, spondyloarthropathies. And when you look at the entire picture, the presence of obesity reduced the efficacy of TNF-alpha inhibitors. That's when you look at all of these together. When you look at IBD alone, there's a trend, but it doesn't quite reach statistical significance for both Crohn's disease and for ulcerative colitis. But you can see the diamond or the rhomboid is really moving away from the one point here, and there's a trend towards evidence that obesity is actually going to reduce the responsiveness to TNF-alpha inhibitors. Here's another study that shows visceral fat is associated with reduced mucosal healing on infliximab treatment in patients with Crohn's disease. And the visceral fat can be documented here with blue, and the green indicates the subcutaneous fat. But again, the visceral fat can be an indicator that the patient is not going to respond to infliximab. It's important to appreciate, and this was a sort of pharmacological or pharmacokinetic analysis done by Sid Singh at University of California, San Diego, that the visceral fat and the other fat constitutes a higher volume of distribution. And so the effective dose, as it were, of the TNF-alpha inhibitor reaching the colon is going to be reduced. And that's simply why there might be a reduced efficacy. And so we might need to think about modifying the dose per kilogram body weight or per BMI when we're choosing our dose of infliximab for IBD patients. It's important to appreciate that patients with obesity in IBD do not have increased risk of hospitalization or surgery or serious infections. This is a nice analysis from the literature. More than 3,000 patients, 76% on TNF-alpha antagonists, and there's no risk, no increased risk for the patients with IBD, and no difference between Crohn's and ulcerative colitis or what type of biologic therapy they were taking. However, if the patients have had ileal pouch anal anastomosis for ulcerative colitis, obesity is associated with reduced quality of life and increased risk of pouch failure. And so, again, this might be something to keep in mind, and an indication that if our patients have colectomy with ileal pouch anal anastomosis, let's work, as the gastroenterologist looking after the patient, let's work on reducing their body mass index, let's work on the obesity to keep them safer and to make their pouches last longer. Bariatric surgery is safe and efficacious in IBD, and there's reduced medication use. I think this is really important as well. Another indication that we need to work with our patients with IBD, because their need for future treatments with biologics in particular may be dramatically reduced. So there's a decrease in 46% almost of the patients, decrease in the IBD medications that are required by those patients. NAFLD is almost twice as common in patients with IBD as it is in general controls. And this also applies to advanced liver fibrosis, and this twofold increase in the prevalence of NAFLD compared to controls needs to be kept in mind. Bariatric surgery can be performed safely in the setting of liver transplantation. So this, I think, is something that we certainly at Mayo have seen a lot more patients, particularly when they're having transplantation for severe metabolic associated steatotic liver disease. That is also a time when, especially if they don't have complications like varices in the way, they could actually have the sleeve gastrectomy almost performed during the same liver transplantation procedure. Now, that doesn't happen in every patient, but it is an opportunity to help with patients who have both the need for liver transplantation and the need to lose weight. And if you do the bariatric surgery, there's an improvement of hypertension and diabetes in 60% and 45% respectively. Sleeve gastrectomy can be performed. Yes, there is some morbidity and rare mortality in these situations, but overall, the benefits appear, to my mind, to outweigh the risks. Now, fecal microbial transplantation, this is where I'm on my weak point. So we'll just go through this rather rapidly. So 2 reasons pertaining to fecal microbial transplantation, which, as I'm quoting Ahmad Ilmar, the head editor of Gut, it's still the domain of the gastroenterologist and could impact increased signaling, bile acid dehydroxylation, and weight loss. So obese women with uncontrolled eating behavior have fecal microbiome mostly characterized by low diversity microbial steady states. And it's my understanding that low microbial diversity is not a good thing to have. So you see this in so many papers that are evaluating the microbiome. And I apologize, I'm not an expert in the area. So I'm just going to leave you with that fact that there's less microbial diversity. This, on the other hand, is really quite interesting. This is a study in experimental animals in mice. And if you compare the calorie extraction from food and the fat mass in mice who are given a microbiome from a lean mouse compared to mice whose microbiome came from an OB, in other words, a genetically obese mouse, you can see that the microbiome from the genetically obese mice actually extracted more calories from the food that was given to those mice. So there's more calorimetry. Bomb calorimetry shows the fecal gross energy content is lower in obesity, and this is consistent with increased harvest of calories from the diet in those mice, which were given the microbiome from OB mice. And similarly, the simplest thing to look at would be the percent body fat, and that's increased in the OB microbiome mice. So I think this is quite interesting, but of course we still don't have enough, as I'll show you on the next slide, to suggest that obese people should receive fecal microbial transplantation as treatment for obesity. There is some evidence that fecal microbial transplantation can alter bile acid metabolism, and this can have an effect on glucose tolerance. This is actually a single study that I know of from Jennifer Allegretti from Boston, and it did show that fecal microbial transplantation in this relatively small study of only 22 obese, metabolically healthy people, 11 received fecal microbial transplantation, 11 got control treatment, and there was an improvement in glycemic control in the ones who got the fecal microbial transplant, the active group as shown here. I think that this obviously needs replication and larger numbers. Fecal microbial transplantation, on the other hand, did not enhance weight loss in patients who underwent bariatric surgery. And so this is illustrated here by the overlapping of the lines in the 2 treatment groups, the placebo group and the fecal microbial transplantation group. And somehow there's an improvement in quality of life, and I don't know what the mechanism would be, but certainly there seems to be a better quality of life over 6 months compared to baseline in those patients who received FMT. So I have a final word, which I think is very relevant to those of us, particularly who do endoscopy, who do procedures, and that is something that's become more and more relevant and prevalent, even in the public domain, in CNN, etc., maybe CBC as well, that there is a risk of aspiration pneumonia. So these were a couple of examples from my own personal experience. Routine upper GI endoscopy. This was not my patient. I happened to be the person doing the endoscopy on the day. And here's a patient who was on semaglutide, no evidence of pyloric stenosis, as you can see here, and the stomach is jam-packed with solid food and bile, etc. So there's no doubt that gastric retention, and of course, this patient has fasted from 10 p.m. the night before. Okay, so despite 8 to 10 hours of or 12 hours of fasting, this patient has residue in the stomach. This, again, is another patient I did see in the clinic. This patient was on dulaglutide, one of the older GLP-1 receptor agonists. And you can see while the patient's on dulaglutide, there's retention of food in the stomach. Only 16.7% of the food had emptied from the stomach at 4 hours. On the other hand, we took the patient with the help of my endocrinology colleague. I said, I think we need to stop this patient's dulaglutide, repeated the gastric emptying a few weeks later, and you can see it's completely restored back to normal. None of the food is left in the stomach at 4 hours, and a lot more has emptied at 2 hours and at 1 hour. This patient is within the normal range for our assay. So the fact of the matter is that these GLP-1 agonists can indeed cause pretty significant delay of gastric emptying. And this comes from the Canadian literature. And I think it tells us a couple of very important potential ways forward. And that is to consider in patients, particularly who are on longer acting agents like semaglutide and retatrutide when it comes available, and tirzepatide, which likely will be available for patients with diabetes in particular. These are medications that are designed to be administered every 7 days. And so they're by traditional pharmacological teaching, we may have to wait 3 or 4 or 5 half-lives so that the blood levels or the tissue levels are low enough not to have an effect on gastric emptying. And so if the patient has a history of nausea or vomiting or feeling full after the meal, and they come to our emergency room and they need an operation, should we be doing on-the-spot ultrasound to see whether the patient has a stomach that's full of solid food? I think that's something we should consider, and that's what's recommended in this article that came from the Canadian Journal of Anesthesiology. So I do think that this is something which we should take seriously. And we had an invited article in the American Journal of Gastroenterology, and I actually made these 2 points. Number one is we need to go back and rethink the recommendations that come from the American Society of Anesthesiology, which I'll show you on the next slide. And also we need to take seriously the possibility that in patients who give us a history of nausea, postprandial fullness, bloating, we should be able to do on the spot ultrasound of the upper abdomen. We need to teach ourselves, train ourselves if necessary, before we put the scope down, before we give the patient the conscious sedation or propofol, whatever you're going to use, to make sure that the patient doesn't have a full stomach. And the third point to make is, remember, we've known for 30 years that if you give intravenous erythromycin to a patient who's had upper GI bleeding and has hematemesis, before we scope the patient, we can give intravenous erythromycin 3 milligrams per kilogram over 45 minutes, and that stomach will empty 100% of the times, and typically 90 or 100% of its content. So those are the 3 points I made in the recent article. But let me just tell you, these are the recommendations from the American Society for Anesthesiology. And to cut a long story short, if you're doing elective surgery, by all means stop these, perform the elective surgery a few weeks, certainly several days, if your patient is on liraglutide. And I keep in mind the principle of at least 4 or 5 times the half-life of that medication to be on the safe side. The Society of Anesthesiology said about a week, I believe, somewhere. I'm concerned that may not be sufficient for elective surgery. So conclusions. Treating obesity is relevant to health in general, as well as impacting GI and liver disease itself. GLP-1 and gut hormone receptor agonists are extremely efficacious in the treatment of type 2 diabetes and obesity. I think the guidelines are needed to avoid aspiration and related complications in endoscopic and surgical procedures. And in summary, I think gastroenterologists and hepatologists should be treating obesity. Thank you very much again for this wonderful invitation and opportunity to be with you.
Thank you, Dr. Camilleri. That was a comprehensive review. I don't know where to begin to think, but just to begin with the questions, that last point, you showed even in your own studies that not everyone has that retention, right? So what do you think so far, even with semaglutide, what percentage were the long kind of sustained dysfunction?
So what we did, that was a study we did with liraglutide. We haven't actually replicated that study with semaglutide. What we can say is that about a third of patients will have prolonged gastric emptying, which persists beyond at least up to 16 weeks, but it certainly persists beyond 5 weeks. The other side of the coin, of course, is that at 16 weeks, 2/3 didn't have delayed gastric emptying, and a third of patients have no gastric emptying delay. And that's why we went back and did that more detailed analysis. And when we sent this as a letter to the editor, the editors of the journal Obesity were very pleased to see that we had done this more detailed analysis, trying to bring it down to what is the proportion that will get the delayed gastric emptying. What I can also tell you is that we studied the genotypes for the GLP-1 receptor and TCF7L2, which tells you about the synthesis of GLP-1. It's a precursor gene modification, and we didn't find any association with genetic variation in those two markers. Our sample size is too small to do a more more in-depth analysis of genetics.
Dr. Sanda, and then Dr. Kasam.
Speak into it.
Excellent review of a very relevant topic. My question to you is similar to what Clarence has asked. What is your practice going to be, considering a health system where significant wait times occur? Are we going to do an ultrasound and cancel patients with precious endoscopy time, or are you going to actually stop the semaglutide or the relevant medication like a week, 2 weeks beforehand?
Great question, thank you. I think there are ways in which we might be able to use standard questionnaires to look at what are the patient's current symptoms. And if they have no nausea and they have no vomiting, they'll have postprandial fullness, I think the likelihood that they have significantly delayed gastric emptying is probably smaller. My own practice for an elective procedure, I will probably tell my patients to stop semaglutide 3 or 4 weeks ahead of time. With patients with diabetes, it's no problem because there are so many other ways to control the diabetes. Put them on an SGLT2, increase the amount of metformin, etc. So there are other ways in which we can collaborate with our diabetes colleagues to maintain glycemic control. It's the patient with obesity that I think we have to explain that we don't want them to run the risk of aspiration. And we want them to take a drug holiday. That's how I'm selling it to my patients, a drug holiday from the medication. Very often we find, I don't have any evidence for this, I said it'll kick in even better when we start it again. But I think we need to make sure that patients who do have upper GI symptoms, that we make sure that we don't expose them to the risk of aspiration.
I'm going to take Chair's prerogative and just fantastic presentation. I think it has so many applications, and thank you. Just, following up, you talked about genetic variations and using that to predict. In your experience and in your analysis, are there any other factors that seem to predict, which patients will respond or won't respond in terms of that gastric emptying piece, or even respond to, obesity management and so on?
It's a great question, and I know that there's a fair amount of research going on to try to identify whether there are genetic predispositions to responding to this type of treatment. I can tell you in our randomized controlled trial, we also looked at those same genetic variances to try to see whether they impact the amount of weight loss. And again, keeping in mind, we had 67 on liraglutide, 65 on placebo. We did not find that those two hand-picked single nucleotide polymorphisms in TCF7L2 and the GLP-1 receptor, we did not find any significant association. And I do think that, considering the large number of patients that are studied by the pharmaceutical industry with all of these medications, I hate to think of the opportunity that has been lost in collecting, venous blood DNA to try to see whether there are predisposing factors. And, I'm afraid I'm too cynical not to make this comment. And that is that the last thing that the pharmaceutical industry wants is to have to restrict the number of patients that receive the medication. Now, I may be shot on my way out, but I feel much more secure saying this in Canada than elsewhere. Oops, and we're online, right?
Well, we are.
Yeah.
So maybe Dr. Hallen, and then actually some good questions online too. So Dr. Hallen.
Thanks again for that. You presented some of the data on inflammatory bowel disease and increasing medications. That seems to be another fact of a lot of those medications being weight-based, infliximab is a factor, or people coming off medications, developing agents. How with that data did they drill down on that bit? Some of those medications are seem to be weight-based, and that may kind of be an artifact in that data.
It's a great point, and I honestly would have to go back and look at the data as it was collected in those systematic reviews. And the person who's really done a lot of this work and who's an expert in the systematic review methodology is Sid Singh at University of California, San Diego. And so I do think that some of the questions that you've asked, and very appropriately, may be answered, but I don't have the answer off the top of my head.
So maybe I'll merge the two online questions. They're asking about clinical predictors of persistent delayed gastric emptying. And then the other question from one of our endocrinologists is, again, what's your thoughts about permanent changes to GI motility after taking a GLP-1 agonist?
Okay, so again, unfortunately, I don't think we have any good evidence of who is predisposed. What are the risk factors for developing the delayed gastric emptying? We tried to go down the path of, we even did some analysis of electrocardiograms to look at the RR interval, which tells us about vagal neuropathy. We didn't actually publish those data, but we didn't see that vagal dysfunction was so prevalent in patients with obesity to constitute a risk factor. So at the present time, I'm afraid we still don't have any real answers to the questions. And I think the same answer would apply to the question from the endocrinologist.
Dr. Russell?
Thank you. I very much enjoyed both your theme and your data, and I'm sure the honorees would be proud to have someone like you give the talk.
Thank you.
I have a comment and a question. I have always assumed that the resistance to anti-TNF therapy of the various diseases you mentioned was related to the production of TNF by visceral fat, and so neutralizing it. Do you think that's a reasonable assumption? Or?
It certainly could be that it is neutralized. Quite honestly, that's not my area of expertise. And what I can say is that Sid Singh's data is really based on association. It never really came down to understanding whether there was resistance that comes from something produced by the visceral fat, or whether it was just a matter of increased body of distribution, reducing the effective dose that goes to the tissues. So that's the best I can do.
And a quick comment, as a rheumatologist, I feel I have to point out that you missed out on your list of obesity associations, a very important diagnosis of osteoarthritis, not merely because of weight, because it affects the hands too.
Fair enough, and thanks. I'll make sure I add it to my next time I give the talk.
That was a magnificent summary of the particular drugs like semaglutide. I still am unclear about the mechanism of weight loss with medication. How much of it is related to presumably the early satiety that happens because of effects on gastric motility versus more metabolic central effects, the role of insulin, for example, as a hunger hormone, and actually suppressing that. Can you speculate maybe how that all fits together?
Yeah, great question, Dan. So I do believe that if you look at, for instance, some of the picture that I showed on oral semaglutide, where the contribution of GI adverse effects, which wasn't actually studying gastric emptying, but it's using the GI adverse effects of nausea, vomiting, constipation as a surrogate, there is some contribution, but I'm not going to claim that it's all caused by delayed gastric emptying. There's no doubt that these medications have effect on central mechanisms, hypothalamic centers, hedonic appetite, control is very, very important. So I do believe that there is a very significant central effect. I do believe that some of the effects on, the traditional glycemic hormones, insulin, glucagon, is also very important. But I suspect that it's multifactorial. But from the standpoint of the gastroenterologist perspective, especially now that we're starting to see these potential adverse effects, we've got to keep in mind and stay in conversation with our endocrinology colleagues in particular, that the GI tract is not something to dismiss as the potential not only for risk of adverse effects, but also for benefit. And I think that, our analysis of the NIH-supported liraglutide placebo-controlled trial does give some weight to the argument that degree of gastric emptying delay can contribute to some of the weight loss.
Thank you for the great talk. One quick question about moving the what was your approach in terms of realization of the drug? Because it takes 3 months to reach to the target dose, whether it's Gamma, Lira, or there's a price which is better than watching it than the next one. So that's a very good question in terms of implications for the patient. Because if we start on seeing higher dose, the risk of complications from the question we mentioned.
Thanks. I'm hoping I've heard and understood the question, but I do believe that the experience that we had when we did this randomized controlled trial was we dose escalated liraglutide at the way in which the FDA approved the drug. So we started with 0.6 milligrams. Next week, we went to 1.2, 1.8, 2.4, and 3.0. And in some patients, we couldn't dose escalate every week because they had GI adverse effects. But if we waited an extra week in that dose escalation, we often were able to reach the maximum. In fact, something like 85% of the patients on liraglutide were on 3.0 milligrams for the last 12 weeks of the study. So I do think that your point is very well taken, that as we dose escalate, we might also be able to assess the patient's GI adverse effect and either slow the dose escalation or reach a target which the patient tolerates. And we had 1 or 2 patients at 1.8 milligrams and 1 or 2 patients at 2.4 milligrams where we couldn't escalate any further. So I think we need to use clinical acumen and converse with the patients and see them, or at least have the opportunity to converse with them by phone while we're doing that dose escalation, in order to make it possible for them to get the benefit from these treatments. I hope I answered their question.
Yeah, so it was mainly about drug holiday, for example.
Oh, drug holiday.
So then probably they need to restart from lower dose. So let's say if someone was already on 1 milligram of semaglutide or 3 milligram of Lira, we held it for 4 weeks, then we start the meter from 0, from lower dose.
Yeah, in all honesty, I don't know whether there are any data to really advise us on how to do it, but I take your point that it may be necessary to start the dose escalation again from a relatively low dose.
One more, just sort of maybe, and just online, just the question from Dr. Bertozzi about long-term effects of GLP-1. Do you think there's a concern we should be telling our patients about that?
Again, what we have is what's in the literature very often with, even up to 2 years of treatment. And it appears that at that stage, that there are no worrisome effects in terms of, for instance, malignancies or anything like that. That's certainly not that I have encountered in the literature. Long-term, is it conceivable that the beta cell of the pancreas is going to become more fatigued? Are the patients going to be more insulin dependent? I don't know the answer to that question either, but it's something that needs to be addressed.
Okay, last word to Dr. Mason. Last question.
Michael, thank you very much. That was an excellent talk. So I'll ask you a liver question. There are data going back to the 80s about a very high prevalence of what I would refer to as non-syndromic fatty liver disease in IBD patients. So studies of
up to 80% of patients with IBD having fatty liver. And at that time point, the obesity epidemic was just starting, I would say. So there wasn't the sort of 50% to 2/3 of the population that were obese by that time. So my question is, do you know what may trigger fatty liver disease in thin people with inflammatory bowel disease? And then the second question is, what effect does the gleritide, etc., have with those patients' disease?
They're two very, very relevant, very important questions, and I'm afraid I have absolutely no answer for either of them. But I'll try to pose those questions to my hepatology colleagues when I get back and see whether they can provide some further information. Maybe for the next time I come to Edmonton. Thank you.
Dr. Camilleri, thanks once again for an amazing lecture. Thank you so much.